My name is Ellay Gutmacher. Since yesterday, I'm a dentist, and I'm also a PhD student. Thank you. Thank you. My supervisors are Andrea Brody and Akos Jembery. My SMS is Esther Agnesh Salai. My vision is to facilitate global healthcare by better understanding the oral systemic health axis, and my mission is to do it by providing evidence that saliva can detect systemic diseases. Currently, we have two ongoing projects. The first one is investigating the salivary levels of Fusobacterium nucleatum in patients with colorectal cancer. And this is done by the methodology of systematic review and meta-analysis. The co-author for this project is Balin Jombor. So colorectal cancer causes more than 930,000 deaths per year, and this is estimated to increase to more than 1.6 million deaths by 2040. Currently, screening tests such as colonoscopy can prevent early colorectal cancer by detecting malignant polyps and removing them. However, unfortunately, it has some geographic barriers that contribute to the late diagnosis of the disease. In addition, it is an invasive, uncomfortable, and it potentially can harm the patient, which also contributes to the late diagnosis of the disease. As an example, in the USA, nearly 22 million risk individuals have never been screened for colorectal cancer. We know that Fusobacterium nucleatum is an oral pathogenic bacteria that is associated with colorectal cancer. It was also found that the bacteria accelerate different types of cancer in different types of cancer, such as breast cancer and also pancreatic cancer. Recent studies showed that the bacteria is found in the colorectal tissues of patients with colorectal cancer and colorectal polyp, and also that the higher the abundance of the bacteria in those tissues, the lower the survival rate of the patient. Therefore, we suggested a method to detect colorectal cancer using those saliva samples from which we would be able to quantify the DNA levels of the bacteria. And by that, we aim to increase the detection rate of colorectal cancer. And for that, our aim was to investigate the diagnostic and prognostic value of salivary FN in colorectal cancer patients. So we asked, is there a difference between colorectal cancer and healthy or precancerous patients in the salivary FN DNA levels? To answer it, we used the PECO and the PERT framework. For the PECO framework, we hypothesized that patients with colorectal cancer have significantly higher levels of the bacteria compared to healthy individuals and compared to precancerous patients. And for the PERT framework, we hypothesized that salivary FN can accurately predict colorectal cancer. So we started with nearly 14,000 studies and finished with 12 eligible full texts. And here are our results. So here we investigated the presence of Fusobacterium nucleatum in saliva among the colorectal cancer patients and the control groups. This is important because patients with colorectal cancer usually showed symptoms at the late stages of the disease. So early detection opens up more treatment options, and it leads to earlier treatment, and by that it can save lives. So to assess this outcome, we used the odds ratio with 95% confidence interval, and we included 8 prospective cohort and case control studies divided into the healthy and the polyposis subgroups. The heterogeneity was 0%, which is very low heterogeneity between the studies, and the pooled odds ratio for the presence of the bacteria in patients with colorectal cancer was 49% higher in patients with colorectal cancer. However, this could be clinically relevant, very clinically relevant, but it did not reach the statistical significance. So our second outcome was the relative abundance of Fusobacterium nucleatum in saliva among colorectal cancer patients and control groups. To assess this outcome, we used the mean difference with 95% confidence interval. We included 5 prospective cohort and case control studies. The heterogeneity was 0% as well, and the pooled mean difference for the relative abundance of the bacteria in saliva was minus 0.04, which is neither statistically nor clinically relevant. The strength of our study was its novelty. It focused on vulnerable population. We could include individual patients' data, and this allowed us to further interpret the results and to expand our investigation. We included studies from different continents, and the limitations were the differences in the measurements of the bacteria in saliva, and also the low number of eligible studies. So based on our results, we could conclude that the presence and relative abundance of the bacteria in saliva are not associated with colorectal cancer, and for the practice, we implied that salivary FN alone as a biomarker for colorectal cancer should not be recommended. For the research, we implied that other non-invasive markers that can replace colonoscopy should be investigated as well. 4 days ago, our article was finally accepted, and we are now waiting for the publication in the Scientific Reports journal. Our second project is evaluating the diagnostic accuracy of salivary C-reactive protein in neonatal sepsis, again by the methodology of systematic review and meta-analysis. So we know that every year about 3 million infants die in the first month of their life, and 98% of those deaths occur in developing countries. Neonatal infections, including sepsis and meningitis, are responsible for more than 400,000 deaths per year, with 9 to 20% of those deaths that occur due to severe neonatal sepsis. The signs and the symptoms of the disease are non-specific, and this quite often leads to unnecessary antibiotic treatment. We know that serum CRP plays an important role in the treatment decision of the neonates before the physicians receive the blood culture results. However, it requires blood samples whose processing relies on laboratory supports, and these take several days usually. In addition, the blood samples lead to phlebotomy losses, and this causes moderate pain in the neonates. A recent study showed that salivary C-reactive protein could be non-invasively, easily obtained from saliva, and also that it can accurately predict neonatal sepsis. So that's why our aim was to investigate the efficacy and performance of salivary CRP for the diagnosis of neonatal sepsis. Our question was, could salivary CRP accurately detect sepsis in neonates? For that, we used the PERT framework, and we hypothesized that salivary CRP could accurately diagnose neonatal sepsis. We started with nearly 5,000 studies, more than 5,000 studies, and we finished with 10 eligible full texts. And currently, we are on the stage of writing the manuscript. And here are our results. So here we evaluated the diagnostic performance of salivary CRP in diagnosing neonatal sepsis. To assess this outcome, we used the sensitivity and specificity with 95% confidence interval. And we included 5 prospective cohort and case control studies. And pooled the overall diagnostic performance of salivary CRP to detect neonatal sepsis had a sensitivity of 85% and a specificity of 87%. So based on our results, we concluded that salivary CRP is an appropriate diagnostic tool for neonatal sepsis. For the practice, we implied that salivary CRP may be used to predict neonatal sepsis. And for the research, we implied that future research should focus on standardizing the salivary CRP measurement and its diagnostic thresholds. So to summarize, the first article was accepted, and the second one is expected to be submitted in August this year. And we'd like to thank you for your attention with a quote from Albert Einstein: "The most beautiful thing we can experience is the mysterious. It is the source of all true art and science." Thank you.
I'm doing similar microbiological study, and I was wondering, what is the normal value of this Fusobacterium nucleatum in relative abundance to the oral microbiome community? Mm-hmm. Is it very low?
Yes, so thank you for your question. So it was very different across different studies, and also a lot of the data, we had to extract it manually. But some studies, it had like even 0.01%, and there were some studies that even like 2%, which is quite high. So it was differing, but mostly it was around 0.01 and 0.03, around this 0.0 region.
Yes, because this is an anaerobe bacterium, and if we just take it from saliva, I don't think it's in a very big amount in that area, most probably in periodontal pockets. So I was just wondering if the amount of this bacteria is so low, then even in diseased cases, we would probably not see such a big difference, and maybe that's why it's not suitable to be a biomarker.
I agree, thank you.
Okay, I still have questions regarding this. Do you think that in colorectal cancer, the oral cavities Fusobacterium abundance changes? Because the GI tract is very long, and we know that in the oral cavity and the rest of the GI tract, the community of the microbiome is definitely not the same. Why do we suppose, was there any background information that if we have a colorectal cancer, this community is going to change in the oral cavity?
Yes, thank you for this question. So it was all based, first of all, on there is already or there are studies already in the literature that show that there is correlation between the colorectal cancer and also the Fusobacterium nucleatum, but in the colorectal tissues, not in the saliva. And there is also few meta-analyses on this. And that's why, also there are studies, not meta-analysis, but there are studies that show that salivary Fusobacterium nucleatum may originate from the oral cavity, and through the periodontal tissues and through the bloodstream, it can migrate to the colorectal tissues. So that's why we were thinking maybe there is, like, maybe maybe there is association. Hopefully, we were hoping for maybe causative factor, and hopefully we were thinking maybe it could be diagnosed from there. So this was the basis. Also, it was that was the main bacteria that the literature talked about when talking about colorectal cancer.
And something related to this is that our project with Caroline also has to do with bacteria, only in the cardiovascular system and the oral cavity. And we have found many strains of this one specific species that we are working with. The Fusobacterium nucleatum probably has different strains. And do you know which strain is more abundant in which area of the GI? And are they the same virulence in causing certain disease? Because probably Fusobacterium causing periodontitis could be a different strain than that found in the colon, for example.
Thank you. So regarding which subspecies are more abundant in different areas in the digestive tract, I'm actually not sure, but of course I will check it. It is interesting. There were, from what we could see, there were 4 subspecies, and I think so. One of them was Fusobacterium nucleatum subspecies nucleatum, and there were 3 more, but currently I cannot remember the names of them. But I think the most abundant was the subspecies nucleatum, if I'm not wrong.
That have you considered in these studies checking the primers of these bacteria that they used for detection? Yes,
thank you. So we also extracted we didn't extract the primer, sorry, because some studies didn't give it, so there was not enough information, but we did extract the control gene to see. We could only compare studies that had the same reference gene. If there were also other studies that had actually positive results, positive association, but the reference gene was not the same, so it was a pity, but...
Yes, maybe there were, obviously there weren't enough studies, and also the type of PCR they use, if it was very sensitive to that species or not.
Yes, so they used PCR, qPCR, metagenomic tools also.
Two questions. One is about pain, I'm sorry, but how do you measure pain in neonates?
How do I measure what, sorry?
Pain in neonates.
Neonates, a good question, actually.
Thank you.
Thank you. I never thought about it. It's from the literature, the moderate pain. Of course, I'm not a neonatologist, but it's a good question. I will consult with my team.
They often use what's called a FACES pain scale. So, but often also they get maternal or mother's report as well. So, so it's very interesting. But anyway, aside from that, salivary biomarkers. There's been a lot of work done, and I know NIH in the US is investing more money in the hope that that there will be. Now, what I understand, and correct me if I'm wrong, but there are no actual approved biomarkers. I think they use some in COVID as sort of emergency biomarkers, but can you just comment on, you're doing some really interesting work, and excuse the blunt question, do you think there's a future in salivary biomarkers research?
Thank you for your question. We'll start with your second question. It's a really good question because theoretically it seems the best and the easiest to just use saliva and detect any disease because it's non-invasive and it's actually very easy. Even non-professional people can do it, but it has a lot of disadvantages, such as from what I could hear that the saliva usually sometimes contains food debris, not in the case of neonates, but food debris. It also has a lot of factors, confounding factors that influence on the components. And regarding your first question about the biomarkers, one biomarker that is used also today for the detection of sepsis is the serum CRP, and this was actually the reference test which we compared to the salivary CRP, and the threshold for this is 10 milligram per liter, and it is not, it is 100%, from what I could see in the literature, 100% sensitive, but this is only a temporary finding until the blood culture arrives from the laboratory. Also, there is procalcitonin, and there is, from what I could see in the literature, salivary procalcitonin, not salivary, but serum procalcitonin. It also has a really good diagnostic accuracy or association with, if I'm not wrong, it was with sepsis. Yes, with sepsis.
You mentioned that these bacteria were studied on all continents almost, or several continents. Is there a basal difference, the number of bacteria in the different population, or could you compare the same levels in every population? Because diets are quite different among these populations, what you have listed here.
Thank you.
And we know that even coffee can influence very deeply the microbiome in the gut.
Absolutely, thank you for this question. It's a good question because we also wanted to know if there is a difference in the culture, in the continents regarding the abundance of the bacteria in saliva, but unfortunately there is not enough studies to give any significant finding about it. Of course, there were different studies from different regions, but maybe there were two studies that we could include that were from the same continent. I think Asia, or maybe three actually, but still it's not enough because we need also studies from other continents to see any associations. So we couldn't answer this question, unfortunately.
Colorectal cancers are similar ratio in all these places?
Colorectal cancer, I think it was similar. I'm not sure, but I think it was quite similar in all of the continents, but I will check it again, of course.
What is rather common, and I will have another question after that. So this relative abundance is quite a tricky effect size measure, especially in meta-analysis, because if someone uses one kind of primer, the other one uses another kind of primer, and one comes up with a relative abundance of 0.1% and the other with 2% abundance, they are absolutely not comparable with each other. So I think in the case of meta-analysis, it's better to use the presence or absence of a bacterium. This was the common part. Okay. And my question is related to your second topic, that you mentioned that the salivary CRP was used as the diagnostic, was tested as a diagnostic tool. And I have two questions. My first question is, isn't some very minor amount of CRP already present in the saliva?
Thank you for your question. So I think there is minor amounts of salivary CRP, and that's actually what we tried to see in the research. But I think it's very, very minor amounts. It's actually, I'm not sure about the correct amount of salivary CRP without any infection. But again, the different studies had different thresholds for the CRP level in the saliva, and it was really, really different. Like some, I think it was 3 milligram per liter, and the other was 0.01 milligram per liter, so it was really hard to compare them. But regarding the exact amount of CRP in the saliva without infection, I am not sure there is a consistent finding about this, but it is interesting, yes.
Thank you. You already mostly answered my second questions about the cutoffs of the CRPs in the different articles, because usually in these kind of biomarker studies, they say that the cutoff is, let's say, the mean value of the whole population or the first quartile and stuff like that. So there is no unified cutoff yet for the...
No, unfortunately.
Okay,
thank you.
I still have a question, because it just came up that these studies with the salivary CRP, they are going to have a control group, no?
Yes, so the study with salivary CRP, the control was the serum CRP. We also had, yes, that's the problem. We also had actually studies that reported the blood culture, and we actually had we did a meta-analysis, but there were only 3 studies that we could include about this. So it's not really relevant. Yes, so we only could compare it to serum CRP. It's not the best, but that's what we have.
Yes, and how much saliva sample is needed from these neonates? Because it's very difficult to collect saliva from these little babies.
Yes.
Is it really saliva, or is it going to be a buccal swab?
Yes, thank you. So it was saliva, actually, and the studies used different techniques to collect it, the saliva. But I think the most abundant one was a special tool that first they had to rotate the baby's face, and then they had to apply this tool. This tool had a vacuum or suction. It's an electronic device, and it somehow sucks the saliva, and the volume was around 1-2 millimeter. And also, if it was not enough saliva, then they had to repeat this application.
About this saliva, also because we did research and we published actually very early in COVID. And then and later on others too, or in parallel with others too, that showed that actually this kind of COVID-19 could be identified from saliva as well as from the nasopharyngeal samples. And I think here that's very important that not everything in saliva is coming from the salivary glands. So we don't have to focus on salivary glands. I mean, when we talk about, we talk about salivary, although this is actually what is in the mouth, and that's a mixture. And then if we say that, for infectious diseases, at that time, we and others developed actually different technologies. Really used the saliva, which is a very sticky fluid, so therefore for laboratory people, laboratory medicine people don't like that. But at that time, that clearly, that became really clear that saliva, what you collect from the mouth is really, equal to many other methods what you could use, and non-invasive. Thing one. Thing two, the most promising thing and then we're also actually planning to do some meta-analysis on that line, is the exosomes. Because the big problem with saliva is the standardization of collection into samples. So therefore, if you want to do a kind of quantitative measurement of glucose, for example, there was yesterday somebody, actually, that she showed her data, and that's very difficult, that the methods are not very well standardized, so therefore very diverse. But if you have well-standardized methods, actually, this could really work well. The other thing, if you just have a yes or no kind of data, like from exosomes, cancer, oral cancer, pancreas cancer, gastric cancer, other cancers, saliva could be really a very useful method for diagnostic, very early diagnosis, and very easy diagnosis in terms of collecting the samples. So, here, because we deal with this, actually multiple groups at the dental school, we really believe that this is something very important. Only we have to find a way, and then we also have to see your limitations. But really promising, I think. And then these results, these negative results are extremely important, because so many people reported before that Fusobacterium is there. But they did actually a non-controlled study, non-controlled studies. So that was the notion that this is an important thing for colorectal cancer, although that is there actually in everybody's mouth. A very important study.
Thank you.